thanks for having me. Thanks for the invite. It would be great to get some interaction. It's exciting that we can interact and ask questions, so I'd encourage people to do that as we're going along. I really just want to go through as much clinical stuff as possible tonight. Obviously, it's difficult in a forum like this where we are just doing a lecture, but I do want to keep it as clinical as possible with mention of some really relevant and perhaps some new evidence. So let's get into it. So this is just a little bit of a brief aside to start with. This is our clinic in Hawthorne, and as Gavin said, I'm very lucky at the moment to be able to specialise in tendons and basically spend most of my time seeing tendon patients. So I spend about 3 days a week in clinic where I see primarily lower limb tendon patients that have failed other interventions. So it's a good opportunity to really get a grip of things that work and I guess things that don't work so well, and some of the things that we can do to improve the management that is offered. So just these are contact details for me. There's a I think email address and I think if anyone's not on Twitter, I really encourage you to get onto Twitter. It's a fantastic way to stay on top of all CPD. I think we're so spoilt these days with webinars and blogs. There's a lot of information. The problem is sifting through it and actually looking at it all. Okay, so we'll get right into it. First of all, some brief sort of background. We all are familiar with normal tendon as a connective tissue. It connects muscle to bone. Its primary function is to transfer tensile forces, and it's very well adapted in doing this. Another function of some tendons is that we have this potential to store energy, to store and release energy, and that harnessed energy allows us to a lot of the time move more efficiently, and also potentially increases power in human movement. So it is a really important function of tendon, and what we tend to find, particularly in the lower limbs, that the tendons that do this type of energy storage and release are the ones that tend to get injured as well. So there are sort of some negative and positive aspects to energy release, particularly if you're doing too much of it. So this tends to happen in the stretch-shorten cycle. So what happens here is that the muscle tendon unit stretches and stores energy, and then that's followed by a release of energy as you go into from an eccentric to a concentric phase. There's a bit of debate about how much eccentric and concentric activity is actually happening. And it depends on muscle, it depends on the task, it depends on the speed of the task. So, for example, in walking, we know the gastroc and the calf is primarily isometric, and you have a stretch shorten that occurs in the tendon, which is a very efficient way to operate for the muscle. And this is where the tendon really can improve efficiency in our movement. So if we look at the structure and review the structure of tendon, I really don't want to go on about this too much today, but I think it is important if we're starting to talk about pathology. So the key thing to think about is that we have tenocytes that are arranged in parallel, and we have ground substance and we have collagen. So if you think about sort of a collagen-based connective tissue, that's really what tendon is, with some ground substance. Now, ground substance is just proteins that bind water under high pressure, so similar to what you'd find in cartilage, and this allows a little bit of compressive strength. And we know the collagen is really well adapted to for tensile strength. And we know that tendon is probably the most well adapted and the most organised tissue for this tensile type load capacity. We know tendon has a blood supply, has a nerve supply, as you would expect with all tissues. There's been huge debate and sort of different opinions about what the extent of the blood supply is, how important it is in pathology. We know really for a normal tendon it has an adequate blood supply and a good blood flow response to activity. Whether or not there is a hypervascular environment later on in pathology is still debated. So one of the things to really talk about and focus on is the emphasis of the tendon, because if we look at all of our lower limb tendons, except for the mid portion Achilles, they tend to break down at the emphasis. And structurally, it's a weak link because you've got a union of one tissue to another, and the body tries to do this in a smooth way by gradually changing from a tendon-type tissue to a fibrocartilage and then eventually to bone. But we know there is huge concentration of stress at these sites and also a lot of compression, which Mike Benjamin from Cardiff has really looked into over the last few years, and people are talking about clinically. We also know that there's lots of tissues around the enthesis that can be pain-generating, like the fat and the bursa and the paratendon. So it's a complex area for diagnosis as well as management. So we're going to move on to tendon pathology, and we're going to talk about the tendon itself and some of the surrounding tissues in brief. I guess one of the key things to clarify is what do we call tendons and what's the terminology we currently use. The main term is tendinopathy, which is an all-encompassing pain or pathology. So clinically, that's the really good term to use. Tendinitis infers inflammation, which we can't really tell, and again is a hugely debated area. Tendinosis implies degeneration, which we know that it's something that has been talked about probably more recently, following the inflammatory the burst of the inflammatory bubble. But again, we know that's a simplistic view as well. It's not as straightforward as saying we've got a degenerate or an inflammatory tissue. So clinically, I don't know whether these terms help us very much. The other term that is a little bit debated, or really no one can agree on, is tendon tear, which you can really never tell for sure clinically, although I personally believe it's a clinical diagnosis that is very rare and is probably radiologically diagnosed too much, but I think we'll go into that. So this is sort of the view that I tend to think about, or sort of my perspective of tendon pathology. We have lots of stuff that goes on a cell signaling level, and this is where you get your mechanotransduction, which is a really sexy term at the moment. People are talking about, biochemical responses to load, and you have lots of growth factors and cytokines and inflammatory factors that do all sorts of wonderful things to adapt tissue. Now, we don't know anything about these, or very little about how this operates in tendon. We probably know more about healing, because that's an easy model. You tear a tendon, you can see how it heals. But in that overuse model, we really have very limited evidence about what happens. And what we know the endpoints are of pathology are tissue changes, so pathology itself from a morphological point of view, and pain. And that's what we can see clinically and we can measure. So that's how I tend to think about it. It's almost like a black box of cell changes and biochemical changes leading to the outputs that we see clinically. So we do have some understanding that perhaps there is a change in how the progression of pathology goes, and I think the reactive-degenerative model from 2008 by Cook and Purdom is a really good way to think about how pathology could be ordinal. So what it proposes is that we have, and I'm sure everyone's familiar with it, we have a reactive tendon which basically involves increase in ground substance and possibly more cellular activity, but a good maintained matrix, and it's a diffuse response, and that goes on to a more focal degenerative lesion, which is a breakdown of the matrix with ingrowth of blood and nerve vessels. So that's the theory, and there is some evidence to support that, mainly from some imaging studies and some animal studies. So I guess the important thing to focus on, though, is there are limitations to any model by definition, and with the reactive-degenerative model, we know that pain and pathology aren't really correlated. So what's talked about is that perhaps a reactive tendon can be, can be more painful when you have this sort of diffuse response in the imaging, followed by a degenerate tendon that is less painful. But we know that many people have degenerate tendons that are very painful and irritable. So that pathology pain, and that's something that the authors have acknowledged and talked about. But I guess the problem is that less enlightened people would treat pathology, and that's one of the real dangers of having a model that mixes the two. You can have people, and I come across this all the time when I talk to physios other professions that treat tendons. People think degenerate pathology we do degenerate treatments with, but really the main focus should always be pain. So I guess this takes me to a really important question, that is, do we need imaging? And I would argue that we don't for staging tendons. I've just got a bit of an issue. My screen's disappeared.
Hi Peter, what issue are you having?
I can't see. It's saying I'm going to exit in 5 minutes. It's saying I've just got to exit. It came up with a screen warning, you're going to exit now. Now I'm in the webinar exit 0.
Okay, so you just need to click the link again to join. It sounds like you lost connection.
Okay. Oh, okay. Hang on. I'm in the right one now. Sorry. Bit of a moment. Okay. We're still on?
Yes, we are.
Okay. Sorry about that. So, do we need imaging? No for staging tendons is what I'd argue, because if we have a reactive tendon on imaging, which is a diffuse thickened tendon, the degenerate model suggests that we are careful with the loading, because it may be that if they've had this acute reactive response in the tendon, we need to be careful with the loading. But the issue with that in the clinical world is that we really need serial imaging to do this. So it makes sense from a screening point of view, but we really don't do that clinically. And the second thing is, second main recommendation of the reactive-degenerative model is to load to adaptive-degenerative matrix. But there are huge difficulties with identifying and monitoring adaptation, especially with ultrasound. And I think in the future, perhaps with things like UTC, which is ultrasound tissue characterization, a new type of imaging that is really in the research world at the moment, being used a little bit clinically, things might become clearer. But clinically, the pathology on ultrasound is such a poor guide and often doesn't correlate with pain. And as I say, unless you're doing serial imaging, really limited value in doing ultrasound to stage tendons. Where imaging can be useful is as a differential diagnosis. So this can be very, very good. And this is what I tend to use imaging. I use ultrasound imaging for all the Achilles, patella, hamstring, basically lower limb tendons that I see. The important thing here is that it must fit in with the clinical picture. So, for example, you've got an Achilles paratendon fluid, history of sudden and dramatic change in load, diffuse symptoms that are not fitting in with an Achilles tendon. We see pathology all the time that doesn't fit in with the clinical picture, and then we ignore it. So, for example, I recently had someone with a paratendon problem who had symptoms of paratendon that was localized to one side of his Achilles, and that's what we saw on imaging. So, pretty good evidence, given also his load history, that fit in that he's got a paratendon problem. I treated him, he got better, he got back to running, and when I imaged him a few weeks later, his paratendon fluid was exactly the same, so it hasn't changed. So the pathology itself isn't causing pain. It's underlying processes possibly associated with that pathology that can change even when the ultrasound stays the same. So although you can use it for diagnosis, I think long-term screening with ultrasound is you're on very shaky ground. Okay, so that brings me to partial tear, which is another really debated area. There's degenerative tears which happen commonly in some tendons like supraspinatus, but also other tendons in the Achilles, in the gluteals. And they basically just happen as a sort of sequelae of your degenerative pathology, and they're nothing really, often don't correlate with clinical symptoms like weakness and pain very well. And then there's acute tears which happen on a background of pathology when someone does something that is a very definite episode or incident, and these people come in and they can really remember the exact time when they did it and the exact moment, and it's a definite change from their sort of baseline up and down symptoms. So this is a real different thing. This is often associated with an acute loss of strength and acute pain. And these ones we tend to treat symptomatically because they tend to happen in areas that are already degenerate, so therefore they don't tend to be that long-term of an issue in terms of that person's pain. Having said that, sometimes you can get continued weakness. So if you see them acutely, they may not be very weak, but if you see them acutely, they might be very painful, acutely painful and weak, pain inhibited. If you see them 6 months later, sometimes they have a loss of strength, but their pain has settled. So when these people are very difficult to rehab and their strength is not coming back, sometimes that is an indication that that weakness from that actual acute tear can be significant. But most of the time I spend in clinic, I'm convincing people that degenerative tears are something they should ignore. I spend a lot of my clinical time doing that because it doesn't often influence prognosis at all, and people get very, very scared and very worried, and there's a lot of nocebo going on because people are worried about these partial degenerative tears. So on to pain then. There's lots of theories. Basically, in a nutshell, there's lots of theories, but no one knows really what's causing pain in tendons. So we have sort of recovered from this neurovascular theory. People are still talking about it, where you have Doppler, and that was initially associated with tendon pain in some early studies that weren't very good quality. Now, and the underlying theory was the nerves associated with these with the Doppler may be causing pain, and that may still be the case, but Doppler is a very poor marker because we know that Doppler itself, and this is for people that don't know this sort of colourful stuff that you see in ultrasound, we know that Doppler is often, we know that Doppler is often, it's just a very unreliable measure. There are biochemicals that are associated with abnormal tissue like substance P that can be associated with pain, and we know that tenocytes can produce a lot of these biochemicals, and a current theory is really centered around tenocyte involvement and biochemicals, but really there's little concrete evidence of what the nociceptive mechanisms are in tendon, and clinically we don't really know what the underlying biochemical environment is when we have someone present with different levels of pain, different pain presentations. So we need to remember that pain is an output, and it's not nociception is not equal to pain. So we can have central sensitization, and a good example of this is the hyperalgesic to palpation response we have in gluteals, which is very, very common. But I see patients all up and down the lower limb that have signs of hyperalgesia, and very importantly, it's not a differential diagnosis because you clear those, so it's not something else going on, but they do have, often because they've had a long history of failed treatments, and I think I see a biased population because they tend to be the people that come and see us, they will have signs of central sensitization. The other thing to really, and that's one thing. The other thing is all pain output is central, so there will be cognitive beliefs, psychosocial factors that will modulate pain potentially even from day one. So even not in chronic patients. So we need to be thinking about beliefs about pathology and pain much more, I feel, than what we do in tendon patients. And this happens in athletes that have huge amounts of anxiety about making a tournament. And it also happens in, sedentary people who just have freaked out about fears of rupture and pathology. So I think this is an area where we can improve in terms of our management of tendon, and that is this importance of education and positive pain messages and avoiding nocebo, which is hugely, hugely common, particularly from certain sort of medical groups that will really highlight pathological issues. So if we look at fleshing out the model, then we know that pain is an output, and it's somewhere out here, potentially associated, but who knows how much, with what's going on here on a cellular level. So really what we need to be looking at, and we know that tissue change pathology is not associated with pain. And that's mainly because pain is an output and it's so multidimensional, not only nociception. So we need to be thinking very broadly when we're thinking about pain. The other thing that we need to think about moving on to is inciting factors. So what incites tendon changes? And really the two main inciting factors are compression and energy storage. So these are massive. And you need to be assessing for compression, how much compression they have, how much energy storage they're doing. And I think I'll talk about that when we go into the clinical part. We don't know why these load drivers. We know compression probably increases sort of ground substance response and causes some cellular activity in relation to that. And energy storage, don't really understand completely how that links to tendon pathology. But we know these two factors are related. So let's turn to more clinical stuff then. What do we need to assess in a clinical setting? Most important thing, number one, I'll go through 4 things. Number one is pain profile, so how irritable are they? And this basically sets up your whole treatment. So are they stable, where the pain is flaring for less than 24 hours post-load? Are they irritable, where the pain is flaring for more than 24 hours post-load? And that really sets up your whole management. Because if they're stable, you can load them. If they're irritable, you need to manage their pain. And it's basically as simple as that, regardless of what the mechanisms are, regardless of how much central dominance or how much nociceptive pain you think they have. It doesn't really matter when it gets to this stage of management. It's all about settling symptoms or loading them. The other thing to think about, it is sometimes important to think about whether they have tendon versus central dominant pain. And we know pain is an output, so it's always central. But how much of it do we think is, how do we know the tendon's actually causing it? And we tend to think localized or recent change in load, clear stimulus response, so they load and they get pain for a couple of days, and particularly stimulus response to compression and energy storage. That's going to start you thinking about the tendon more, and perhaps you're going to be thinking, the only reason to think about that is perhaps you're going to be thinking about more tendon-centric interventions, like maybe you do want to change the biochemical environment with some tenocyte modulating factors, and we'll talk about that in a second. If they've got central pain, they might have neuropathic pain. Like I had an Achilles patient today, typical Achilles patient, symptoms, he's had it for a long time, huge amounts of hyperalgesia where you can't even touch the tendon. And he had a bad reaction to cortisone where he had 6 weeks of pain, which is very, very atypical, but indicating some hypersensitivity in the nervous system. And now you can't even touch his Achilles, and he's got bursts of pain. So you get bursts of neuropathic type pain. So you do see these people, not very common. And as I say, usually after they've had failed injections or something's gone wrong. But they will also have a blurred stimulus response relationship. So it's not always that they're going to get a flare-up after load. Sometimes they get a huge flare-up, sometimes they get less of a flare-up. So they're the types of things you're thinking of central. But the important thing to remember is there's always going to be central modulation. So whether or not they've got central sensitization, they're going to have central modulation based on their, other factors that we talked about. So central pain correlates with all these factors. So we need to be assessing their beliefs, and we need to be asking them, do they have a risk of rupture? I think most Achilles patients do have a risk of rupture. And a lot of them believe that pain is going to equal harm. And there's huge fear avoidance, anxiety, and other factors. So we've started to measure things like cold and pinprick hyperalgesia and pain pressure threshold in some of these patients. And that's been interesting. The other thing to start to think about and really get a good measure of is their load profile. So it's important to think about their goals, where they want to get to. But also, it's important to think about just how much loading they were doing and how much that changed leading up to their injury, and then how much that has changed after their injury. So I assess what I call the 168 hours in their week. So basically all the sitting, standing, walking, sleeping, postures and time, as well as other activities. And other activities will be things like sporting activities, gym activities, and it's also really important to assess how much heavy lifting they do at work. One of the real difficult patella tendon patients is you're labouring type patient who is going up and down stairs kneeling, because that is often a barrier to them improving. This is something that I'd like you to go away and probably have a look at in more detail. But it's something that we wrote for a recent paper on just management of lower limb tendons, and going through the hamstring, the gluteal, the patella, the Achilles, and the plantar fascia. What sort of compressive factors do you want to avoid, or what sort of things cause issues? If we go through one example, so for example, hamstring, sitting on hard chairs, strategy for dealing with it, sitting on cushions, increased anterior pelvic tilt, and this happens in sitting. People are often told to sit in huge amounts of anterior pelvic tilt because it's good for their back. It's terrible for their hamstring origin, so we tend to get them to sit in a more neutral or posterior tilt position. And also dynamically, loss of control, lumbopelvic sagittal plane control into anterior pelvic tilt. So you can do retraining of posture and movement, or just avoiding those positions. So stretching hamstrings, obviously something you want to avoid as well. So I'm happy for people to have the notes, and that's something to have a look at, but about avoiding compression. Okay, third thing to really hone in on is their systemic profile, and this tells you about the capacity of that tendon. So have they got any metabolic diseases or hormone issues that will predispose or reduce their tendon capacity? Their age is another factor. Fluoroquinolones, inflammatory arthritis, they're factors that can lead to real inflammatory type problems where you have sudden onset bilateral severe tendon problems, whereas the other systemic problems, these ones here, they are primarily associated and sort of modulate the load response, but they can make it much easier for someone to get a tendinopathy. So it sounds like, so what I mean by that is with even much less load, they'll be predisposed to a tendon problem. And the last thing in terms of subjective that I really hone in on is their past history of injury. So really often you find they've injured the muscle of that tendon, or they've up and down the kinetic chain or on the opposite kinetic chain. So this is really important because fluoroquinolones and antibiotics used to treat UTIs and other things like that. Not very common in Australia, but they are prescribed. So basically just look out for all your kinetic chain factors, which I'm sure everyone's doing. In terms of objective assessment, I do use palpation. I think palpation is very, very useful for picking up central sensitization, hyperalgesia, and also apprehension and avoidance and really sort of guarded type behaviours that we see with some of these patients. That's the main reason I use it. The other reason I use it is differential diagnosis. So I think there's some real uses for looking at feeling tissues and looking at pain response from different tissues. So if we look at an example of differential diagnosis and palpation specifically, in the hamstring, there's so many diagnoses that can give you this sort of hamstring pain. And so there's the hamstring origin, there's your hamstring. So if we look at sciatic nerve should be here. So one of the things that we tend to hone in on in terms of palpation is palpation of the sciatic nerve interfaces. So it's going to come out through underneath performance, come down here, and it's really just lateral to the hamstring origin. So you can get people into side lying and palpate, and often a sciatic nerve involvement will be presenting very, very similarly. The only difference is that it will be not pain at the hamstring origin, but along one of the interfaces of the sciatic nerve. And it can be very localized, just like a hamstring origin problem. Often they'll have some pain if you really question them at other sites as well, like the back or down the leg. But this is where differential diagnosis, as an example, can be very useful for looking at exact site of pain and reproducing their pain with palpation. So that's good. Moving on with the objective assessment, loading tests are also important to establish the stimulus-response relationship. So you want to establish pain with loading. And you want to try and use an increased load progression. So for example, with the Achilles, I tend to do single leg calf raise over a step followed by jumping on 2 legs followed by jumping on 1 leg. And what you're assessing is how much pain they have out of 10. And you might get them to repeat it 5 times and see how much pain they have out of 10. Obviously with the Achilles you want to see where it is as well. Is it in dorsiflexion? Is it in plantar flexion? Because we know there's compressive issues in different positions. But you want to get a pain, what I would call a pain load aggravating factor. So out of 10, what's their main pain load ag? So you might have your patient that's very irritable and they're down here in their pain ag. Less irritable patients, hopping might be their pain ag. Really non-irritable patients may have no pain with hopping. That's not very common, but it does happen. Gluteal, you might do something like a step up followed by a hip hitch in terms of increasing load. So you can use whichever type of loading test you want, as long as you get a good pain loading ag for all your tendon patients. And then the other thing that's critical to examine is the kinetic chain. So looking at the kinetic chain function, and the important thing to do here is to look at movements and look at movement patterns that are specific to their function. So if you've got a walking person, you need to look at them walking. You've got a runner, you need to look at them running, and then you can break up those movements. So step ups, squats, double and single leg, hopping and jumping, depending on their activity, depending on their function. So what do we look for? I tend to look primarily globally at movement to start with. So and again, I try and find a movement ag or a predictable load movement deficit. So I try and find one predictable load deficit, one predictable kinematic deficit for each patient. So that could be within a step up or within a squat or within a run. They're doing something that I think is related to their pain and related to tissue load. So I try and link it to how much load there is going through the tendon and how much compression there is. And if you can do that, then you can start to think about what are the underlying causes to that predictable kinematic deficit. And then you can think about, can you change those underlying causes? And then you can test whether that improves their pain. So that's the way that I tend to look at people, mainly from a global kinetic deficit and then to looking at contributing factors. So some of the common kinetic chain deficits you'll get are stiff strategies in the knee are really common, Achilles and patella, but a lot of other tendons as well. Very compliant strategies where they've got a lot of high peak joint range in their ankle and their knee. And then you've got things like, obviously, coronal and transverse plane issues around the hip, which are really common with gluteal tendon and some of the other tendons that we see as well. So there's lots of things to assess there in terms of kinematic deficits. And then you've got hopping, and there's lots of stuff in hopping. So, poor eccentric control and stiff strategies, overly compliant strategies, etc., etc. So there's lots of things to look at. And I tend to look at video and slowing things down, trying to find the most meaningful and most related to tendon load movement deficit for that person. And I try and focus on that. And then you're looking for the contributing factors. So is it fear, apprehension, and pain? And you need to try and remove these factors systematically by giving them confidence or trying to improve pain. And then you're left with things like flexibility, motor output, and biomechanics. So can you link any of these to that motor output issue or kinematic? It could be none of the above. So often there's the kinetic chain, and I think the more that I see these tendon patients, the more I'm really cautious about hanging my hat on kinetic chain deficits that you assess in clinic, mainly because it's so unreliable, the assessment of these factors, but also often they're not related if they're minor. So we need to be thinking that A, they're pretty major, B, there's a clear load link with the movement deficit or the tendon pain that you're dealing with. So how does this information guide our management? So I guess that sort of rounds off what I want to talk about clinically with assessment. If we move on to management, how does that change our management? So basically, the main goal, the number one goal for any tendon patient is to manage their pain. And pretty much gone are the days when we are trying to sort of Hock and Alfredson style push people into pain and really increase their symptoms, drive them into symptoms. I think that sort of approach, we sort of pretty much accept now that it's okay for some people and it does work, but it doesn't work for a lot of people, and especially people with more irritable pain. My view these days is if you can manage pain very effectively, it gives you a really good footing to the rest of the rehab. So thinking about education, tackling the nocebo associated with tears is a huge one. Tackling the rupture risk is a huge one, particularly for the Achilles. So I ask all my Achilles patients, are you fearful of rupture? Do you think it's going to snap? And basically they all say yes. So it's something that we need to try and put into perspective for them, because in probably over 10 years of specialising in tendons, I've told a lot of people they don't have a risk of rupture, and thankfully no one has actually ruptured that I've said that to so far. So I think that's pretty good, and I'm willing to sort of continue to say that based on that. In terms of pain, we need to be giving them positive pain messages. Some pain is okay, and it's really important that we avoid fear avoidance associated with pain beliefs, and also just expecting flare-ups and expecting some variation in their pain. And I think these messages reinforced over and over and over and over again to tendon patients are very, very important. And it's important to give them really good time frames and goals. So we talked about those contributing factors up here. So when I find contributing factors and movement deficits, we try and make goals around those significant movement deficits and those contributing factors, and they are the things that they sort of strive for. So if you can give them some goals that are associated with function as well as with pain, it's often much better for them to focus on achieving a functional goal. The other thing with pain management is obviously reducing the abusive loads, so the compressive and the energy storage type loading. We can do a total ban. And if they're very irritable, you might say to them, look, you need a few weeks of just not doing any compressive at all. I had a hamstring origin patient this week who I've just got to stop sitting completely, because that's one of the things that we sort of is maintaining a pain cycle, and she's quite fixated on it as well. So we've just taken out sitting completely from her, and she has a sitting job. So it's not an easy thing to do, but it's possible if you are getting to a point where you just can't settle their symptoms. Take away as much as you need to settle their symptoms to a really good level. And don't be afraid to be aggressive with doing that. If you can argue to the patient, at least you're going to help them. And then monitor that obviously every week and see how much effect that has. And if it's not having an effect, then you need to rethink it. Otherwise, some people you can do a graded reduction, so you progressively reduce the amount that they're doing based on how they are coping. So loading, isometric loading is quite a relatively new thing. So some really good research by Ebony Rio. He's one of Jill Cook's PhD students looking at isometric loading in the patellar tendon, which basically take-home message, it reduces pain in the short term. It does improve pain in the short term. So in that initial phase of rehab, when you're really struggling pain-wise, isometric loading is a good adjunct to all your education and your load management. I don't really buy into central sensitization as you need to do things differently. Basically, it's all about education. I don't do much of the... I would look at stress management. I would look at stress management and meditation if that's a real issue for them. And sometimes, well, for research purposes, we look at screening for anxiety and depression. But it's not something that I do huge amounts of with tendon patients. But I think if you get their education right, even with the ones that have got a large central component, they will do well. In terms of other things, so adjuncts, I tend to do a lot of dry needling, soft tissue work. Ice is good for short-term pain. Manual therapy, there's absolutely no evidence, but that's okay. That doesn't generally tend to stop us. As I say, I tend to do dry needling and a lot of soft tissue work. Tape, brace, wedges, splints. I think about it, what are the mechanisms? Possibly reducing compression, possibly just putting some sensory input in to get a different output. So you might reduce the loading rate. Who knows how they work? But I usually take a trial and error approach based on guide from a little bit of clinical information. So it might be oh, they've got limited or they're getting into real huge amount of dorsiflexion. Try a brace, see if that reduces their dorsiflexion. So trial and error approach guided by some clinical information. The next level for reducing pain in terms of adjunct things is anti-inflammatories and steroid, which may have a tender side effect, but then again you've got to be clear that there is tendon pain there. I tend to use steroid very, very sparingly. You've got to be very careful because obviously the problem with steroid is people get worse in the long term. So if you're using it once around a tendon when they've got a really big event or something happening, fine. But try and manage their pain. Otherwise, I think from experience what we've learned is that if you can manage their pain with other things, it's often better, i.e. the load management education. Okay, so let's talk about loading then. So we did a systematic review very recently where we looked at Achilles and patella tendon loading programs, and we looked specifically at studies that had compared two loading programs. So one loading program to another loading program in the Achilles or the patella. And we also looked at potential mechanisms. So I'm not going to go into detail of the study, but what we concluded were that there were very limited studies that actually looked at comparing loading programs. And what we found is that eccentrics is not clearly superior. There's equivalent evidence for Silbernagel program in the Achilles, which is a concentric eccentric program, and greater evidence for the heavy slow resistance or HSR program in the patella, which is also a concentric eccentric program. So the take-home message is you don't need to necessarily do eccentric training with your Achilles and patella tendon patients to get good outcomes. We also found that neuromuscular outcomes like strength improved, but imaging did not improve. It did in some studies, the poorer quality studies, but if you look at study quality, there wasn't any evidence that imaging actually improved in the long term. So that fits in with this feeling that, and this other evidence that when you get to this end-stage tendon, when you've got a certain amount of pathology, and especially matrix breakdown, it doesn't actually reverse. And again, it reinforces the point, should we be using imaging as an outcome when we know it doesn't reverse or it doesn't change. So in terms of stable pain, when you've got someone with stable pain in the clinical setting, your main goal is to address their kinetic chain deficits and progressively restore their goal function. So that's really what we tend to try and do. And this is the criteria for doing it. So isometric exercise, if they're very painful. The main reason to use isometric exercise is if they've got pain with isotonic exercise. So if you've got a calf patient who can't do a calf, I had a calf patient today who had 4 out of 10 pain doing a single leg calf raise. So what we said to him was, you've got too much pain to be doing calf raises. Do your isometric training for a week or two. Let's see how that calf, and stop all your abusive load. Let's see how that calf raise pain goes. They can start isotonic exercise like a calf raise when they can do it with minimal pain. And here they're generally doing either strength type dosages of 4 sets of 6 to 10, or they can do endurance type dosages for glutes, heels, and for calf. Calf, I often do a bit of strength, a bit of endurance, but it depends on the athlete as well. And then usually this phase here will take anywhere between 2 and 8 weeks, depending on how much weakness and atrophy they have. And then in this phase, they're starting to do power, so jumping, running, change direction, all those types of energy storage activities. And they need to have good strength, so equivalent strength to the other side. And they also need to have no reaction to energy storage. So they need to be, what I mean by that is, generally when I start them on a, so if we take the example of Achilles again, they need to have good strength in their calf, comparable both sides. And I use a 10 RM test to judge that. And they also need to have no reaction to They also need to have very low pain, is what I mean, to things like hopping. So that higher load energy storage, they need to have very low pain. If you're looking at a hamstring, it could be very low pain with an arabesque. So something that is, you might do a fast arabesque, so some energy storage, compressive type loading, they need to have minimal pain with that, and they need to have good strength before you start them doing energy storage. And then once you've gone through energy storage and you've progressively done some progressions here of a slow increase in loading there, then they can start to do their reintegration of sport in a gradual way as well. So with the isometric stuff, they can generally do it every day. With the isotonic stuff, they generally do it every second day. And with the power stuff, they generally do it every second or third day. And the same with the sport. That's generally how the sort of rehab process goes. Now, one of the questions, I think I'm going to come to this, but is how long does it take? But I think I will come to that. So, is pain acceptable during rehab? I think we've pretty much answered that. The tolerance of pain during rehab is really changed. We don't accept that much, except maybe a little bit more for the Achilles and patella, but generally you don't want them to have any more than 1 or 2 out of 10. That's what I tell my patients these days. And I know it's quite subjective, that rating, but minimal pain during rehab is what you're after. And it's all about the education that you give them about pain and allowing them to accept that a little bit of pain is okay. But we've certainly gone away from this chasing pain model, the Alfredson model. Does it need to be heavy, and how intense does it need to be? If you look at the evidence for tendon adaptation, it all suggests that if you basically load the tendon more heavily, so more intensity, and more time, so more time under tension, you get a better response and better adaptation in the tendon. And that's all well and good, but it's not realistic for all patients, like your older patients, from a number of people who don't have access to heavier loading type equipment. So I think for younger patients and athletic patients, it tends to be a reasonable thing to consider, but maybe not for some groups. And the other question is, do we need to isolate? And obviously we're just recovering from this sort of, it has to be eccentric type mentality. And the question is, do we need to isolate? And I would say definitely not, based on clinical experience and also the evidence. You don't need to isolate. People get better without. There are potentially some benefits to isolating. You can load them more heavily, and that will lead to greater adaptation. You can also potentially have an effect on length tension. So if you recall length tension, the optimal ability to produce force in a muscle is around a certain joint angle, and it varies for certain muscles, but most of the time around the middle of that range. Basically, if you do a lot of eccentric loading, what has been shown to do is that length tension optimal range shifts towards the right. So if we look at an Achilles example, if you've got an Achilles patient who hops or runs, and when they run they have excessive amounts of dorsiflexion, they get into potentially a range of motion in their calf that is not optimal at that end range dorsiflexion. And we also know that end range dorsiflexion is the time in the hop as well as the running cycle when you have the maximal amount of load on the Achilles. So if you're working with a compromised length tension at the time when you've got maximal load on the Achilles, there's certainly potential there for overload and overuse of the Achilles. So I think it makes a lot of sense, but it needs to be done at the right time, and people need to not be symptomatic into extension. Many Achilles patients are symptomatic into extension, and obviously you don't want to do it for insertional, you don't want to do it for plantaris tendons, and some people, basically, clinically, if you drop them over a step and they're painful in extension, you want to be very careful with loading them into end range, dorsiflexion, I mean. Yeah. So then moving on to energy storage, basically you have a number of ways of doing it. Number one would be return to sport gradually. So some people don't have a huge amount of deficits when they're doing jumping and running, and they don't need much they don't need much input. They can go straight back to running. This works really well for runners, just going gradually back to running, particularly with a little bit of running retraining. It's something we do quite often for runners. That tends to work really well. And you can do it, you know, I'm not sort of wedded to any particular run-walk program or walk-run program. It can be very accelerated for some people if pain's not an issue. It can be much slower for other people if pain is a little bit more of an issue. If they have deficits, though, in their energy storage, or if they've had a long layoff from doing energy storage, then you might consider some specific energy storage rehab. So here we tend to do things like running and sprinting. So if you want to make it specific to their sport. So for example, footballers need to run and sprint, they need to jump and hop, they need to have skills. So you think about you know, change direction, you think about all those things specifically for that person. And I guess the key is to build it progressively, increase volume first, and do it every second or third day depending on their pain response. So volume prior to intensity. So you can flesh out programs, and usually if they've had a long layoff or they've got deficits in their power, it will take them a good 2 to 6 weeks to develop through these phases, usually more towards 6 weeks. Sprinters do a lot of hopping and progressing to faster acceleration, and runners tend to do a lot. I tend to give them a lot of hopping and progressing back to running if they've got deficits in their hopping. You can also add specific posterior chain power work like sled and scooter. For certain groups, it's really good for calf and hamstring patients, but also anyone who's got a posterior chain deficit. And I tend to do, in terms of, I think, yeah, I'll talk about that in a second. So how long does the rehab take? That's often a really important question. And it really is dictated by dysfunction and pain. So if they've got both, if they come into you and they're really weak and dysfunctional and they're really painful and irritable, then it's going to take 6+ months. If they've only got dysfunction, then it's much easier. Some people come into us and they're just scared. I shouldn't say scared, but they're just concerned about pain, but they don't have much pain. But they might have some underlying weakness. So you can address that as you would in an S&C type framework, strength and conditioning, and they get back in 2 months or less, because their pain's not an issue. Pain is much less predictable in terms of outcome and length of rehab. In terms of some ideas about adding energy storage and how to progress it, tend to, this is just an example, but you might, week 1, add in some double leg jumps. And this is an example of a runner who's returning after a 6-week layoff. So you might give them some double leg jumps, and they might do that 3 times in the first week. Add in some single leg hops week 2, as well as the double leg jumps, and then add in some box hops week 3, and then you might progress back to, you might think about assessing their hopping again. Their hopping's better, you start adding some running in, and you might be doing 2 run sessions and 1 hop session or something like that at that time. So the idea is to address those energy storage deficits, make them more powerful, make the power similar side to side or their motor output, and then return them back to what they want to be doing. Okay, so in terms of summary then, I guess the key points that we've gone through, diagnosis is the most important thing with all tendons. I think out of all the tendon patients that I see, probably about 30% are misdiagnosed or something is missed from the presentation. The other important thing is to assess pain very, very carefully, so the irritability, whether it's tendon or central pain, which doesn't hugely change your management, but it does it does sometimes where they're central or tendon driven. So the example of, do you give them lots of anti-inflammatories, you know, if you want to affect a tenocyte or something like that? Well, clearly not if they're very centrally driven. The other thing with central pain or central drivers is you want to really address that education if they've got some of those associated factors. So modify load, educate adjuncts for pain is going to be your most important interventions, and then progressively load to goal function. So that's basically, hopefully, what we've gone through with a little bit of clinical stuff. Imaging is only useful for differential diagnosis at this stage. Maybe with new technologies that will change. So thank you very much for listening. Don't forget Twitter. And also, if you're interested in more detail one of the things we do, look up this link, and there's courses, 2-day tendinopathy courses that we do. I think there's a couple coming up in November. But if you've got any questions about today, let's talk about them now, or otherwise we can, please email. Thank you.
If you would like to ask Peter a question, please type it in the chat box in the bottom left-hand corner of the screen. Peter, there's a few questions have come in. Can you see those?
I think so. Do I start from the bottom?
Yes.
Okay. Okay. Someone's asked, how do you assess compression? Good question. Basically, the best way to assess compression is you ask them all about their postures, and you ask them all about the positions they're in. So it's mainly a subjective assessment. You're looking at are they standing in anterior pelvic tilt, which will be compressing their hamstring origin? Are they standing with anterior sway, which will be compressing their Achilles origin? So it's basically an assessment of their postures and their standing. It's also an assessment of their movement patterns and how they move. So if they are going into eccentric dorsiflexion in a hop or in running, then they're likely to be compressing their Achilles insertion. So you're looking at two things. One is they're asking them about their postures, and then two is looking at their movement patterns. Got some other questions. Clinical diagnosis of plantaris involvement. Okay, really interesting one and very debated. I was recently at the Tendinopathy conference in Oxford, and there were people there who were saying that they, so for example, Håkan Elfsson would diagnose it quite a lot, and he's written a lot about it. I see a lot of recalcitrant, not responding Achilles, and I look for it specifically and look for specifically the signs and symptoms associated with it, which are medial Achilles pain, often worse in dorsiflexion, and you don't often see it. You do see it, but it's certainly not in 50% of recalcitrant cases, which is some of the numbers that have been reported. So medial Achilles pain, medial tenderness. Basically, whenever and this is one of the things we go through a lot in the course, you've got to be very, very careful with the side of pain, because often people will point to the medial side of the Achilles, the lateral side of the Achilles, and people tend to think clinically that's just Achilles pain. But actually, there's lots of other things that can be going on, especially when they point away from the Achilles. So we've got to be very, very clear on that. Okay, so that's plantaris. 10RM test. 10RM is 10 repetition max. So basically, you need to get them into a leg press, leg extension. You get them doing squatting, you get them doing deadlifts, whatever machine weights you're doing, and you get them to do 10 of one thing before fatigue. That's how I tend to test strength. Neuromechanosensitivity contributing. Any addressing of neuromechanosensitivity? I don't really understand that. Louise D, if you can rephrase that. So that's physio. Should we not administer Elfson's eccentric protocol for mid-portion Achilles? Now, Catherine N, that's a good question. I think we can. There's no problem with doing the Elfson protocol. It's one of the evidence-based protocols, but we need to be clear that if they've got pain in end range dorsiflexion, you don't want to do it. And you also need to be clear that you can probably achieve similar things doing other programs, so you don't have to. It's one option. One of the caveats I'd say for not using it is that if you've got someone that is very, very, very weak in concentric strength, and that's usually the older demographic, they often need concentric strengthening, because if you do just a purely eccentric program, they're not going to potentially get that concentric strength better. Do you use compressive strapping for the patella or groin straps for reduction? I do use groin compressive garments, but I don't use patella tendon compressive straps because I just don't feel like they offer that much. Some of my patients do find them useful, but not that often. Is there a role for dry needling? I think there is, but not into the tendon. I tend to dry needle into the muscle only. And there's a recent study that showed that if you dry needle into the muscle, the tendon has, it's almost like a warm-up effect. You have, you know how when you're running, the tendon becomes more elastic, and it happens, within sort of 5 or 10 minutes of running. It's the same sort of thing. It becomes more elastic, so some of that viscoelasticity goes out of the tendon. So I tend to dry needle muscle rather than tendon. what's the incidence likelihood of re-rupture of an Achilles on the same or contralateral side? The incidence on the, if you've got a rupture, you've got 170 times increased risk of rupturing the other side. So there's a massive genetic increased risk of doing the other side, but still, it's not that common. It does happen, but it's not that common. So I don't think. I think we just need to take people's focus away from rupture. And as I said, I've thousands of Achilles patients. I tell all of them that they're unlikely to rupture if they've got pain, and that's true. If they've had pain, they're unlikely to rupture unless it's been interfered with by injections multiple times. But I think we should be one of our real things that we should be doing is defocusing people away from rupture, which is really scary. So Lisa S has asked about stretching as part of management program. I'm not completely opposed to it unless it is causing pain at the time or they're doing lots of it. So for example, you've got your yoga teacher. One of the hardest tendinopathies to treat is the hamstring origin, the yoga teacher, because they love to stretch, and they're also pretty flexible, but they still stretch. So lots of compression. I think a little bit of stretching is okay, but as long as they're not causing any issues, pain during or after. Have you found any benefit from pecking into the site with the insertion? No, I don't really do that type of pecking or dry needling into the tendon itself or at the site, Bryce, but I do know that some people do and have reported some okay outcomes with it as well. Do you change rehab post-Achilles rupture if the patient is more than 8 weeks post-op? With Achilles rupture, I get asked about this a lot. The rehab is really, really straightforward. It is all about just recovering strength and bulk in that muscle. And if you've got one that is really dysfunctional and can't calf raise, so some of them can't even do one calf raise, they might have some lengthening of the Achilles tendon, then it's just a slow process of just isometric, heavy isometric. You might get them into water and do calf raises and walking and other things in water, followed by land-based calf raises and just concentric, eccentric, really focusing on strength. So it's just a real sort of progressive rehab with no, real sort of bells and whistles. In an older Asian patient complaining of lateral wrist pain, tendon tight but not locatable on palpation, fluid on ultrasound, this is a bit of a case study, and pain recorded on bilateral index fingers. I can't answer that. Don't see enough upper limb, sorry. How heavy are the isometrics? Good question. You need to get them to really heavy. We're doing a study at the moment looking at different heaviness of isometrics and how much is good or better. And yeah, so that's what we're looking at. But generally, we look at it on how much weight can you hold there for 20 seconds or 40 seconds, and it should be as much weight as you can hold there. The limiting factor to that is pain, because you don't want any more than 1 out of 10 pain. So minimal pain. Now, if they can hold 20 kilos with 1 out of 10 pain, that's what you do. If they can hold 35 or 40 kilos with 1 out of 10 pain, that's what you do. So basically, just try and max out whatever they can hold for that amount of time based on pain. Is there a collagen marker associated with higher incidence of tendon rupture? There are genetic factors, yes. There are collagen genes that are associated with tendon rupture, if that's what you're sort of asking. So there are sort of tendon polymorphisms. There are genetic polymorphisms, but they're associated, they're not predictive. So that's, yeah, hopefully answering that question. So Alex has asked, what is the best way to measure power? with power, I tend to measure it based on, I tend to measure things like double leg jumps, single leg hops, single leg box hops, hopping maximal height, hopping maximal distance times 3. They tend to be the most effective or the most usual power things that I look at. Some of them are based on performance, like hopping for distance and max hopping. The other ones are based on execution and motor output, like hopping, single leg hopping. There's lots of things. There's probably 10 things, 10 deficits that you can identify with single leg hopping, and that's more just control and issues that will lead you to certain contributing factors that might be causing them. That's basically what you tend to look for. What's your opinion on different NSAIDs and effects? I think I tend to use ibuprofen because that's been talked about as potentially affecting tenocytes as well. Naproxen, a lot of people use. I don't see much difference in terms of which one they use. If you use it at the right time, that's when they've got irritable pain. They tend to have a pretty good effect. Oh yeah, if menopause is a risk factor, how do you address these ladies? That's a good question. So basically, if they're in a systemic group, and that is they've got menopause or lipid issues, or they've got hypertension, or they've got diabetes, then I tend to basically say to them that one of the key things for you is to try and improve your underlying systemic factors, and you can't really change menopause, but you can. What you can do is try and get them as fit and active as possible. So I think fitness and activity and aerobic exercise is really critical for some tendon patients. And what we tend to say to them in the first session is, forget about eccentrics, forget about loading, let's just get you fit, let's get you to see an exercise physiologist 3 times a week. And these are the ones that come in, they're overweight, they've got diabetes, they're in menopause or perimenopausal, they've got some other metabolic factors. They're just, you know, capacity is just terrible, their systemic health is not good. Just take them into a different direction. It's not easy, but the ones that do get fit and do get a bit better with their fitness, they tend to improve. How about the fit skinny ones? Interesting. Yeah, the fit skinny ones, there's not much you can do. So it's a matter of, the way that I tend to see it is it's menopause tends to have this relationship where the tendon pain will come on a few months later. I had an interesting patient this week who had her ovaries removed because of ovarian cancer, and she's now got a really well, long-term, not that severe, but she's had 12 months of tib-post pain and some plantar fascia pain. And she's young and relatively fit, but doesn't have any other metabolic risk factors. There's not much you can do. She's on HRT, but even if they're not on HRT, if they're menopausal, perimenopausal, it's a matter of just allowing the body to reach its own equilibrium, is the way that I look at it. So eventually the body's going to reach an equilibrium, whether it's the pain system changes or whether it's some other systemic hormonal factors, but eventually they get better. So it's not much consolation to them if they're looking at sort of 3 or 4 years of managing something, but often it's just good to tell them that, look, you're going to probably have to manage this to a certain extent because there's underlying systemic issues that we're dealing with. So it's not just loading you and getting you better. And that just sets the scene for them in terms of, yeah, this is going to be tough. Female athlete triad, same sort of thing. So if they are amenorrheic or they're missing, they're irregular, then they often have increased risk, and then you just need to make sure that all their, you know, obviously all the diet and everything else is good, and again, it's just they're going to have a high risk, so you just have to manage that. So it's going to be a management issue, but you do see that a lot in your young female runners. Lots and lots and lots of that stuff, bone and tendon stuff going on. Yeah. I think we're pretty much, can't see any new ones. How effective is hyperbaric treatment for ruptures? I don't know. I wouldn't have a clue. I don't actually use hyperbaric treatment for anything. And I'm not familiar with the evidence or any evidence around ruptures, but there might be. I'm just not sure about that, Julie. How often do you see adductor minimi digiti tendinopathy? What would your treatment be? Not very often. You do see some obscure. I've seen some obscure ones because people find out you specialise in tendons. You do see some obscure ones, but I haven't seen that before. So I'm sorry. Transverse friction on or around the tendon. Generally, people will get a good pain response short term. So pain response short term can be good with frictions, and if you're doing it at a time when, I think it's a pain treatment, basically, is what I'm saying. It's probably modulating pain, and it probably works into, I'm a bit pain sciencey when it comes to all these things now. Probably works into their expectation, and if they, get some effect in sort of periaqueductal grey or some sort of change in, placebo or, I don't know whether it's this mechanism of we're stimulating collagen or tenocytes. I think there's a lot of this stuff, and even with things like EWT, there's got to be pain mechanisms / placebo effects, and that's what I tend to favour instead of this type of stuff, i.e. the friction stuff. So I've got, are there any recommendations you provide in relation to diet and omega-3 and antioxidants? Yeah, I think that is a good thing to consider. Generally, I was discussing this with someone today actually. Someone else asked me this question today about diet, and I don't tend to talk about diet unless I think that it's a systemic issue for someone. So, for example, you've got your clear systemic cases, then I would tend to delve into diet a bit and make sure they are getting some of these factors. Yeah, definitely. If you think they're systemic. Occlusion training, another good question. I think it's interesting you should say that, because we're just about to offer that at the clinic for some of our patients, and I think it's a really good thing to do for some of the patella tendon patients who you just can't get their quads to develop bulk again. The ones that have had it for a long time and just cannot seem to develop bulk again. So, yeah, I think occlusion training could have a role, and yeah, I haven't used it yet clinically, but starting to now. Yes, isometrics for TIB post, lots and lots of isometrics for TIB post. It works really well because it's often very compressed. Because some of the TIB post tendons that you see, when I look at them with ultrasound, they can be 1 centimetre wide, and they have very limited dorsiflexion, mainly because of mechanical compression in dorsiflexion. So you can't do much with them without compressing them when they're like that until they really settle down. So a lot of the initial work is with isometric work. How do you decrease compression of the gluteal tendon when someone has pain walking more than 100 metres? You can get them to walk with a wider gait, so you can retrain the way they walk. To get them to walk with a wider stance, so imagine they're walking with something between their knees. That's the easiest way to do it. The other way to just load manage that. I mean, if they've got pain with 100 metres, they're pretty irritable, and I'd be really looking at other factors and other things that are going on, making sure there's no differential diagnosis. It's not very common for a tendon gluteal patient to have pain after 100 metres unless they're really irritable, but that's one thing you could try. How do you manage those athletes with mid-portion Achilles that function at a high level and struggle with ongoing pain but don't really compromise activity? It's an interesting one. I guess you've got to look at what their pain perception is and how much pain they're having in relation to loading or when do they get their pain? They get it with loading, and what type of loading, and does it really affect their motor output near loading? So if you're answering not much pain with loading and doesn't really affect their loading, then I'd say even though they report a lot of pain, they're not irritable. And they might just have a high base level of pain, but they can still do everything. And you do see athletes like that. So you're just managing them. You want to break the pain cycle at some point, but often you can't until they're off season. So look at how it affects their motor output. You can still manage them in season with isometrics and still managing their load and those types of things. Approach to bilateral gluteal tendinopathy. Not sure, Annabelle, what you mean with that approach in terms of management or... So identifying inflammatory arthritis, identifying a management difference. Well, basically, inflammatory arthritis, if you're picking up someone who's got, basically, someone who's got no load history, so they haven't got a change in load, which you should always be suspicious of the systemic or inflammatory component. And in that case, you want to try and get them to be managed or at least assessed and get an opinion by a rheumatologist. Any evidence of shockwave therapy? Lots of evidence. It's not all good. There's some studies show it works, some studies show it does nothing compared to the placebo. And I think there is a large placebo component. Having said that, I use it on a lot of patients, and I think it's a really good intervention for pain, short-term intervention for pain. Someone's asked, your isometric work is through different set ranges, or do you only load at one range? I only load at one range, so the mid-range position or the least painful. I don't think you need to, because the thing is you're not developing strength in the muscle, it's more for pain. Unless you are developing strength in the muscle, some people can't progress onto isotonic, therefore you might be looking at different types of isometric load. PRP injections, basically, they are okay for some people. Very, very few people get benefit from them. But as a last resort, it is something to try. Although I think probably most people have heard the funding side. The funding for PRP injections has been pulled because the Medicare has looked at it and thought this is not evidence-based. So management of bilateral gluteal tendinopathy in a very high irritable patient. Basically, you need to just look at just the same stuff, just like irritable, manage load, look for systemic factors. They've probably got systemic hormonal drivers, and then you're just going through your same management. One of the issues, and this is what we talk about a lot in the course, is the rehab for irritable gluteal patients can be very difficult, and some of the progressions from lying on a bed doing exercise to standing doing exercise can be quite provocative for gluteal patients. So it's about finding that sort of that turning point or that transition that's going to cause symptoms for them and being very careful with that. So with the Achilles patient, the transition for causing symptoms, the Achilles patient going back to running, is when they start hopping or running. With the patellar tendon patient, it's when they start doing energy storage. With a gluteal patient, it's generally, a lot of them, when they start standing. So standing on one leg can be quite provocative. And I know it's been advocated as a really good exercise for gluteal patients, and I agree that it is, but it can also be very provocative in some of them. So you tend to need to build up to that type of activity and then partial weight bearing, standing, etc. So if she's very irritable, you'd want to be looking at the underlying causes, manage pain really well, check out her nocebo and her beliefs and all that stuff. It's just, yeah, the whole package. Basically all the stuff that we've gone through. Cool. I think that's about it. Can't see anything on this.